Thank you for the invitation to speak here. I've really enjoyed the opportunity to think through these issues, and I hope I can try and elucidate my thoughts with you clearly today. What I've been asked to talk about is engaging healthcare providers in ARV-based prevention, and I've found myself becoming quite practical as I went through this talk, so it's quite practical, I hope. These are my conflicts of interest in relation to pharmaceutical company funding. The outline of the talk is to focus on doctors and other healthcare workers involved in prescribing and providing PrEP, and I'll refer to them as clinicians throughout the talk. And I'll be addressing treatment as prevention and PrEP, and addressing the challenges and obstacles in relation to those ARV-based healthcare preventions, and to offer some solutions. My apologies for not addressing NPEP, time precluded me, but may I refer you to a recent excellent review by Drs. Jane and Mayer. So here's a list of challenges and obstacles in relation to treatment as prevention, and I'd like to go through these individually. Let's think about clinicians' perceptions around their role in HIV prevention, and what I've tried to do in this slide is to look at all the different prevention tools that are there. There's, if you start at the top left, there's contraception, there's treatment for HIV and STIs, there's drop-in clinics, and oh, sorry, I've got the wrong one. I won't use this. This picture shows the Pronto Clinic here in Melbourne, which is a drop-in clinic which is designed to make people feel comfortable about coming in and being tested and treated for HIV. There's people disclosing their status to others. There's PrEP, there's PEP, there's treatment as prevention. There's the community making sense of science and using sexual positioning to reduce their risk of transmission. There's fertility procedures to reduce transmission through pregnancy, needle exchange programs, condoms, including female condoms. And we have, these are the strategies that really are theoretically available to all of us in clinical practice. Theoretically, because many countries may not have them or may only have a mingling of them, if you like. Which of these strategies involve clinicians? Well, in fact, they all do, if you think about it. Every single one of them does. We're either talking to patients and encouraging them to be treated, to have regular HIV testing, to try and use condoms as best they can, to disclose to their partners. We're either prescribing ARVs or PEP, and in some places we are prescribing PrEP. And we're advocating for our patients at all times. So I think clinicians need to understand that we are healthcare, we do play a big role in healthcare prevention. And I think we need to have a shift in our thinking in who we are and what we do. And I just want to make a somewhat poignant note around treatment as prevention, because really, if you think of it, clinicians have been practicing treatment as prevention for a very long time, looking after sick patients. We weren't really thinking about treatment as prevention, but in fact, as science has now shown us, we were actually treating patients and hopefully preventing onward transmissions. Now we think of treatment as prevention, of course, in giving individuals who are weller with higher CD4 cell counts and possibly asymptomatic treatment. But in a sense, we've always been practicing it, and science is now here to show us. The next question is, clinicians are challenged with balancing the duty of care of their patients versus, in regard to the duty of care to the patient's partners and the community as a whole. And we know that if we take an individual and offer them treatment and they take it, then they will become fitter and weller. But as science thankfully always marches on, we also now know from some HPTN studies, and also that recently the partner study, that the treatment affords tremendous benefits in terms of reducing transmission to their partners. And it doesn't stop there, because in fact one goes on to see ecological and community benefits, as was shown earlier, that if you have enough people on treatment, you can drive down incident infections and new diagnoses, and that's been seen in South Africa, excuse me, the United States and Canada. So the clinician is now faced with a really, a very big picture and a sense of tremendous responsibility. They have their patient there, but goodness, if they treat them, then all this could happen too. And I put it to you that here is a nexus where there's considerable opportunity for risk of coercion, both from health facilities trying to, in a sense, coerce doctors to start patients on treatment early, coercion of patients to start treatment to do the right thing, perhaps coerced by their doctors or their partners who want them on treatment. And I think this is quite complex, and we need to be mindful of this. Also, in terms of balancing the duty of care, in many countries, really patients are still so sick that really doctors are really just thinking about treating patients to make them well, and they don't yet have the opportunity to pause, draw breath, and have enough well people to think about protecting partners and community, if you understand. I'm trying to explain to you the mindsets of busy doctors. So the treatment as prevention will not be carried out homogeneously across the globe according to conditions people find themselves in. What about doctors' confidence in the science of early antiretroviral therapy, giving people treatment at higher CD4 cell counts? There's some concern about that, and this graph shows, I think you're familiar with this wonderful table from Dr. Ducoc and El Sadra, showing us that essentially guidelines are giving green lights for starting treatment at different CD4 cell counts. And at the very top of the table, you can see US guidelines are really suggesting that we at least consider treatment for all. If you come to the far right on the x-axis, that's 2012, 2013. And certainly WHO and US guidelines are suggesting people should be treated below 500. But if you look to the right of this slide, you'll see in fact that the evidence favours treatment later. So the strength and the veracity of the evidence favours later treatment, and it's thinner up in the air in terms of the safety and the benefits of treating earlier. So I think clinicians still have some issues around this and have to convey that to their patients. What about patients' eligibility, readiness and ability to start treatment in a sense early and for treatment as prevention? Well, it may not be as straightforward as you think. So in the Temprano study that's occurring in sub-Saharan Africa at the moment, they did a survey of the participants in that study, and 34% of them were in fact unaware of their partner's serostatus, presumably because their partner may not want to be tested through fear and stigma. So that meant that in 34% of cases, you couldn't easily say, well, look, WHO has recommended no matter what your CD4 count is, if you're in a serodifferent relationship, we should offer you treatment. So it's not always going to be easy to identify people who could benefit from treatment as prevention. And I think stigma again is playing out when we find that we have higher rates of loss to follow-up of women who start antiretroviral therapy during pregnancy or breastfeeding compared to women who start antiretroviral therapy when they're sick. Women disappear from those services because we presume they're afraid of being dubbed or seen to be HIV positive. And in terms of simple, pure terms of ART access, patients may not be able to afford it, it may not be available, and country guidelines may prohibit it. So then just flip it around and say, so that we might want all those patients I just referred to be on treatment, but then here's another situation of patient readiness and the time doctors need to talk to patients about being on treatment. So this is a real case. Jason, 32-year-old gay man, single, from Sydney, diagnosed 2 weeks ago. He booked a 5-month holiday starting in 3 weeks. His CD4 cells are around 640, lowish viral load. He wants to start treatment now. But is that the right thing? Do you want to start him on treatment now? So there are all these wonderful caveats and nuances around treatment as prevention where if one thought it would be simple, it isn't. So some of the solutions that I, humbly put before you, certainly around clinicians' perceptions, is that clinicians do play a role in HIV prevention, but I think around the world, different countries, if they don't need to have them, really do need to form HIV societies to work in partnership with affected communities to support and help clinicians better understand treatment as prevention and integrate it as best as possible into their practice. In relation to where do doctors stand in terms of their duty of care to patients and their sense of safety and science, I put it to you that it's clinicians' first responsibility is to the patient in front of them. And when considering starting patients on treatment with high T cell counts, we need to get to know them. We need to understand their lives, their socioeconomic status, to even know if they can afford to take the tablets. That people like to retain their dignity. Of course, they're going to say, oh, yes, I can afford them, or yes, I will take them. They may well not. And knowing individuals' drug use patterns and psychiatric health is really important. I think clinicians need to recognise that stigma will shape patients' treatment decisions, and we need to work with our partners in the community to remove laws that stigmatise our patients. We need to resist coercion from the powers above us, or we need to support our patients if we feel that their partners might be coercing them, or their family, whomever. And we need to hold on tight, because the Temprano studies and the START study results are coming in. Those planes will land, and clinicians will have, I think, a greater sense of comfort, touch wood, when those studies hopefully show that early treatment is beneficial and relatively safe. Now, may I turn to PrEP, and I've listed some challenges and obstacles there, and let me go through them if I may. Clinician awareness, willingness to prescribe PrEP, and experience. What's our experience? Within the largest survey of physicians that was done in US and Canada, about 74% of clinicians, it was a mixed group, said that they would be willing to prescribe PrEP. But their concerns are about adherence, cost, toxicity, and how is it really going to play out in the real world. And in terms of awareness, in a study from Peru, under 60% of clinicians were aware of PrEP. So we have some work to do in terms of increasing awareness amongst healthcare providers. And in terms of the real nitty-gritty aspect of it, what experience do people have prescribing PrEP outside of clinical trials and demonstration projects? Very little. Only about 9% of people prescribed it in the US. We've heard about opposition and stigma both from without and within. And this is something very real that we need to be very mindful of with our patients and when we see them and deal with them. What about identifying eligible patients? The CDC put out a marvellous guidance document recently, and if there were a God, I would say please bless the Americans, because they really do things well. It's a really beautiful document. But I'm just going to be provocative here and say it suggests to identify patients that we question patients about sexual and injecting risk-taking behaviour, and some of the clues about how will I know which patients I should offer PrEP is that they might have had a recent STI or an unwanted pregnancy, and they're very sensible. But here's some questions they suggest we ask MSM. How many men have you had sex with in the last 6 months? How many weren't wearing a condom? How many times did you have insertive anal sex? Were you using crystal meth or speed? Now, that might be very difficult for patients to answer those questions for a whole lot of reasons. They may not ever want to disappoint their doctor. They may have been with them for a long time and stayed negative, and the doctor had worked hard to, hopefully stop them from taking displaying human behaviour that puts them at risk of HIV, and they don't want to lose doctors' trust. Also, we have to take this in context. In some countries, it will be that patients will be criminally liable if they admit to same-gender sex, to sex work and injecting drug use. So we have to adapt these guidelines to the situations. Also, I think clinicians are a little nervous about PrEP in the real world. How will we actually recognise acute HIV infection in somebody on PrEP and monitor behaviour? I'm not trying to be a naysayer, not at all, but I think these are issues, and it might be more difficult to do this in low and middle income countries. But I completely agree with Professor Karim that we really have to just do it. And then if you look at PrEP availability in July 2014 and the cost, the red dots are demonstration projects, and you can see that they're scattered around the world. There's some, in blue, it's some new clinical trials, and the L means it's licensed, and as far as I know, it's only licensed in one country. Now, what's striking about that is really that most of the PrEP available in the world is cloistered within studies. It's not readily available. The other striking thing to me about this, when I put it together, was look at Southeast Asia, look at Central Asia. There is absolutely nothing happening there. It's remarkable. And also parts of Europe, and I must say even South America, I guess there's really not much there. In Australian dollars, since you're here, it costs about $900 a month to be on Truvada, so it's expensive. So the solutions are, apropos clinical willingness and awareness. I think clinicians will become increasingly aware over time, and as data from demonstration projects are published, will become more and more comfortable with and confident and better informed about PrEP. But we do need PrEP drugs essentially to be licensed so that we can get to actually use it and practice it, again harking back to Professor Karim's comment. In terms of stigma, I really think HIV clinicians and their respective societies and peak bodies really need to work and partner to remove laws that stigmatise our patients. We have to be activists. We have to be activists with our partners. I just don't think we can walk away from it. In terms of identifying patients, I think we need to involve nurses, peers, and use computer-based questionnaires to permit patients to have greater candour about what they're actually doing. And we need to partner against stigma, once again, and use clinical guidelines such as they are and adapt them. Not such as they are. Use clinical guidelines and modify them as evidence comes in and adapt them to our situation. As I said, PrEP's only available largely through demonstration projects. I thought it was great that WHO recently came out and said, now's the time, put PrEP into packages for MSM. And that's the push. That's where countries have to step up and say, okay, I think we're going to have to do it. And I'm really looking forward to seeing PrEP available in all those parts of the world where it currently isn't. And we're going to have to work with community, pharma and regulatory bodies to get PrEP licensed and do that urgently. So in conclusion, clinicians, I think, are experienced in HIV prevention. We need to understand that and accept that, but we need more guidance, support and experience in the area of treatment as prevention and PrEP. Clinicians need HIV societies. If countries don't have them, can I suggest that you begin to think about how to develop one or work closely with an extant, efficient medical society, because then we can partner with community and peak bodies to optimise our role in ARV-based prevention. Because stigma and criminalisation will mitigate our ability to really roll these new prevention measures out effectively. We await further science from START, Temprano and many of the PrEP demonstration projects around the world to build our confidence. And it's obviously very clear that we need rapid licensing and subsidisation of PrEP drugs really urgently. Thank you, and my credits. Thanks for your attention.